Good evening. I'm Sherry Binns, the Patient Healthcare Liaison for the Multiple Sclerosis Foundation, and it's my pleasure to welcome Dr. Erin Boster tonight for your questions on symptom management or research or whatever you want to throw out there. Before we get started, though, I do want to bring up a question that has been sort of circulating since the Consortium of MS Centers annual meeting at the end of May. There were four late-breaking studies that came out of Europe that were presented on the last day of the consortium, dealing with older individuals who were taking the B cell therapies. Specifically, they looked at Ocrevus and Rituxan. And they said that in people who were over the age of 55, there was a significantly increased risk of three different conditions if they had been on these B cell therapies for longer than 3 years. And they were a gamma globule or hypogammaglobulinemia, meaning that your immunoglobulins, which help you fight infection, are reduced. So you might be more likely to get infections. The next was neutropenia, and the next one was an autoimmune colitis or gut condition. So, Dr. Boster, I'd like you to just sort of address that really quickly because I've been getting pushback. Dr. Boster says don't let them take you off your medicine. So I'd like you to just talk to them a little bit about those findings.
With pleasure. And by the way, thank you very much for having me back. I'm super excited to be here with you tonight. And thank you for everyone who's jumped online to spend an hour kind of upping your game as we talk about MS. So what we've been learning and what was kind of presented at the CMSC meeting was that there are risk benefits to everything. And if you have been on the B cell medicines, so these would be medicines that deplete B cells. So we're talking about things like ocrelizumab and Rituxan in these trials, but one might consider extending this to any of the B cell depleting medicines. And you've been on them for a minute. So in the studies, it was 3 years. That patients, particularly patients that are over 55, noticed an increased risk of a couple side effects. And one of the side effects is low antibody levels. And so when you've been on the B cell depleters for a period of several years, you might notice that your antibody levels are starting to go down. They also noticed rarely that you can see another cell type go down, which are neutrophils. That's another immune fighter. And lastly, there's been a couple cases of of Ocrevus related colitis or Rituxan-induced colitis. So what do we do with this information? Well, number one, I think that we have to constantly be vigilant and reevaluate the risk benefit of a given drug for a given human. And in the Boster Center for MS in clinic, when I'm looking at someone who's being treated with a B cell depleter, there's several things that I want to explore. Number one, have you had any infections since I saw you last? And if you say no, that's extremely reassuring. If you had a little sniffles or a cold once, okay. But if you're noticing recurrent infections, that's a red flag to me. The second thing that I want to look at is your laboratories. And so I think it's a best practice for patients receiving B cell therapies, all the B cell therapies, that at least twice a year, we're checking a couple things. I like to look at the CBC, which is a blood count, which gives me the white blood cell count. And then underneath the white blood cell count, I can look at all the different types of white blood cells, including the lymphocytes. So specifically, I'm looking at what's called the ALC, or the absolute lymphocyte count. And secondly, I want to look at the immunoglobulin. Now, these are, Scrabble words or doctor words, but immunoglobulin are the antibodies. And if your ALC or your IgG is less than 600, that's a second red flag. Lastly, 55 is not old, like not at all, but it's 5 years older than 50, right? And so every 5 years, if you're 60, you're a bit older than 55. If you're 75, as you crest in my clinic 60, then that's another red flag, if you will, for concerns for infection. And so we will evaluate all these factors to make sure that we think it's safe to infuse. If you are listening and you're receiving a B cell depleter, I think it's a best practice that you have an engaged conversation with your clinician about if you've been having infections. And I think it's a best practice for them to be checking your laboratories. And then together with your clinician, you can sort out if it's a safe endeavor or not. So I'll leave it at that for fear of talking too long.
Thank you very much. For those of you who are new to this format, if you would please type any questions that you have for Dr. Boster into the Q&A box down at the bottom center of your, just to the right of center of your screen. Please leave the chat free for our behind the scene tech to put any questions that are coming in from our Facebook live stream. We do have one question just related to this. It's an anonymous attendee said that her labs or their labs before the last infusion had changed. The IgM level was at 18. I guess the normal range is 50 to 300. My neurologist recommended extending my rituximab treatments to every 9 months instead of every 6 months. The IgA is at 200, well, they said IgM level was at 18, but now they're saying it's at 1030. Is this a common DMT change?
So, and they clarified below that it's the IgG that's 1030. So this is getting very nerdy, which is a great place for me to be, being a nerd. And there's different kinds of antibodies. So the immunoglobulins, the Ig, those are antibodies. The one that I care about is the IgG. I care a less about the IgM and the IgA. So when I'm making decisions in clinic for my patients, I look at the IgG level. We've known for a very long time that IgM will go down with Rituxan and with Ocrevus and Kesimpta and Briumvi. But the IgM is not the key element that I'm looking at. I'm most interested in the IgG, which is the memory antibodies that I look at. And for at least for me, I draw the line in the sand at 600. So I might approach that situation a bit different than your neurologist, which doesn't make me right. It just makes me opinionated. I will share that I'm delighted that that neurologist is checking laboratories, and I'm delighted that you and the neurologist are having a conversation about it with the goal of trying to keep you safe.
Thank you. I have an anonymous attendee who says that they're 43 and their symptoms began around 2022. Loss of dexterity in fingers. They're a musician, so that's problematic. They were given steroids. Other symptoms included bladder problems. This is a very lengthy message. Folks, if you're typing in a message, please don't give us the whole backstory. Just give us a couple of sentences that you'd like Dr. Boster to talk about. Basically, this individual it has not fully recovered from their original relapse. They're on Copaxone and would prefer to be on a B cell depleter. Although they're doing okay at the moment, they're a little concerned about prognosis. And should I be concerned that my neurologist seems unconcerned?
Yes. Yeah, you should be. So the idea that we should start you off on a low efficacy medicine and see how things go, and if things are okay, then escalate to nothing to stay on that. But if you're not doing well, then escalate to a more intensive medicine is flawed. It's incorrect, and I think it's the wrong way of treating MS. And I think that there's emerging data supporting the idea that the earliest application of the most effective medicine is the right way to do this. And so I'm very bothered by the fact that despite that you have a very young age, because gosh, 43 is young, and you've had an attack that didn't fully recover, I would like to escalate your medicine to a more effective drug. And it's it's disconcerting that the neurologist isn't upset, but it's not the neurologist's body. It's not the neurologist's brain. It's your body and it's your brain, and you only get to do it one time. So I implore you to be a good self-advocate and say, hey, look, I'm bothered by this and I would like to upgrade my therapy. And that's my opinion.
Thank you. Another anonymous attendee says, can you please explain what flares are or mean on a brain MRI?
So this is confusing because words sound very similar. So flare is not referencing an MS attack, all right? It's not a relapse. The word flare, FLAIR, stands for fluid inversion recovery. It's a type of MRI sequence. So when you're laying in that tube with the cage on your face and it's loud, it's making different noises. Bang, 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 bing, 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 bing. The different kinds of noises reflect different kinds of pictures. One of the most helpful pictures that we get in the MRI are the flare weighted images. So it's just referencing a type of picture. It's kind of like if you have a camera, you could look at black and white, sepia, color. Those are different kinds of pictures, and flare is one of those.
Thank you. Dr. Boster, Karen would like to know if you would talk about the risk of Alzheimer's in people with MS. Are we at higher risk?
No, you're not.
Thank
So
you.
Alzheimer's dementia is the most common form of dementia in the United States, but having multiple sclerosis does not increase the risk for dementia compared to the general population.
That doesn't mean that we don't have cognitive deficits, but they're not Alzheimer's related necessarily.
Correct. Well said.
All right. What another anonymous attendee, what can be done to ease spasticity besides a baclofen pump and PT?
Oh my goodness. Gazillions of things. So let's just do 8 just for fun. So one thing you can do is you can stay hydrated, right? So being dehydrated will make you more spastic. Number 2, you can prevent being in the cold to the limit that you can. So living in Ohio where I live, that's a little bit challenging, but spasticity is worse when it's cold out. Number 3, you can make sure that you're not super constipated because constipation makes spasticity worse. Number 4, we can make sure that we don't have an infection because any infection will make spasticity worse. Number 5, you can make sure that you have adequate sleep because inadequate sleep will actually kick up your spasticity, believe it or not. Number 6, you can stretch thrice daily. So I love the word thrice, it means 3 times. So stretching helps manage spasticity for several hours. And so I like my patients to stretch when they wake up, before they go to bed. So I call that the bookends of the day, and then once in the middle of their day. Now, just a pro tip, when you stretch, you need to hold the stretch for at least 30 seconds. So doing it for just like a moment or two, your muscle doesn't figure out what you're trying to do. And I would really target the back, the butt, the hips, the hamstrings, the quadriceps, the calves. Those are oftentimes muscles that can be very, very spastic. Another thing you can do is there's supplements, and of course you don't take any of these medicines without talking to your neurologist. There's a supplement called magnesium. So magnesium is taken over the counter, and it's remarkable at helping with spasticity. So many of my patients that don't want to take an allopathic medicine, they'll take some magnesium oxide or something like this, 400 milligrams twice a day, which they can purchase over the counter, and that can help with spasticity. Lastly, number 8, there's a host of medicines that are oral medicines. My fave might be baclofen. There's medicines like Xanaflex, and these can be extremely helpful for knocking out or knocking down spasticity for several hours at a time. So there's a bunch of things that we can do in addition to exercise, physical therapy, and a baclofen pump.
Thank you. This next anonymous attendee says that they're 57 and have primary progressive MS. They've been on Ocrevus for 3 years and want to know if there's some point where annual MRIs are no longer necessary, since there haven't been any significant changes in their recent scans.
That's a great question. I can share with you what I do in my practice. So I like to get an annual MRI of the brain and every other year MRI of the spinal cord, of the cervical spinal cord until age 60. At age 60, we have a conversation, and many of my patients continue to get a brain MRI every year, but some of my patients will start to liberalize, and we might do it every other year. The reason we're getting an MRI of the brain once a year while you're on Ocrevus is to see if there's new spots. Because if we see new spots, even in the absence of worsening disease activity clinically, we know that there's some breakthrough and we want to be aware of that. And statistically, a 20 something is much more likely to have a new spot than a 60 something. And so I have an engaged conversation with my patient and their family at age 60 to decide the frequency with which we continue.
Thank you. Now, hearkening back to our first conversation about the B cell therapies and infections, there's an anonymous attendee that would like you to address UTIs. They've had 3 since December and they've been on Ocrevus for 6 years. They don't state how old they are, however.
So people impacted by MS can sometimes be at very high risk of urinary tract infections because brain and spinal cord damage can mess with the way that the bladder empties. And you can have situations where the bladder retains urine. And, if you had a cup full of urine, it would grow bacteria. And the same thing can happen in your bladder. So, unfortunately, we see urinary tract infections not infrequently amongst people who have MS. Medicines like B cell depleters, which can suppress part of your immune system, might increase that frequency. And urinary tract infections are not something that I want my patients to experience for a multitude of reasons, including they can exacerbate MS symptoms and they can make you really, really sick. And so if you're having 3 urinary tract infections in a period of time on any disease modifying therapy, I'm going to take that very, very seriously. So some things that I'm going to want to do in that situation is I'm going to work your bladder up. I'm going to try to figure out, are you able to empty all the way? We have this gizmo called a bladder ultrasound in my clinic where we can measure the amount of urine left in the bladder and make sure that you're emptying all the way. We also may want to get the help of a pelvic floor physical therapist. So I love pelvic floor physical therapy. These are ninjas. I mean, they look like humans, but they're not. They're very magical. And they can retrain your pelvic floor and improve bowel, bladder, and bedroom. And a lot of times we can improve bladder function through this measure. The other thing that I sometimes need to do is I need to send you to the friendly neighborhood urologist so they can do some advanced studies and understand the bladder. Now, the reason this is so important is there's a bunch of things that we can do to stave off urinary tract infections. Sometimes, honestly, it's as simple as increasing water intake and using proper hygiene when you wipe from front to back. Sometimes we have to do antibiotics after coitus, after sex, or sometimes we need to take a medicine to relax the bladder so you can empty all the way. My point is, we don't accept that laying down. Now, ultimately, if we've done all of these things and we're still having urinary tract infections, we might need to look at the disease modifying therapy to see if it's increasing that risk. There are medicines, I'll use a different example, Tysabri, natalizumab, which is an outstanding medicine, rarely can increase urinary tract infections. I had a patient recently who was doing wonderful on her Tysabri, with the exception of almost monthly UTIs. And after an extensive workup, unfortunately, we literally had to change her disease modifying therapy. And she hasn't had a UTI in 6 months once we made that change. So that's a great question. Thank you for asking.
Thank you. Linda would like some clarification on her MRI report. It said that her whole brain volume is within the second normative percentile. Does this mean that 98% of the population has higher brain volume?
That is exactly what that means. Yes.
Okay. So
People,
that means that she's had some atrophy.
yes, so all humans after the age of 18, their brains shrink a little tiny bit each year. In the same way that we get shorter as we age or our skin may get thinner as we age, this is normal process in aging. But that rate of brain shrinkage is about 0.2% a year. In the setting of MS, particularly untreated or undertreated MS, unfortunately, that can be faster than normal. And so when we hear a point estimate, it doesn't tell us the change or rate over time, but we would assume in that person who has multiple sclerosis that their brain has had accelerated brain shrinkage because of the condition.
Thank you. An anonymous attendee was, I did respond to this person. They said that they were getting ready to start Mavenclad and it was a weight-based drug, and they wondered if 5 pounds one way or the other would make a difference. So I shared my experience with, I just completed my second year of Mavenclad, and I told them what my weight was and what the dose was. That I had to take 2 pills a day for 2 days and then 1 pill a day for the remaining 3 days of each course. And so she says, I was asking about the weight range for Mavenclad to see if I need to wait until I lose weight that I have gained to get back to the weight I was when my prescription was filled. Your response didn't answer my question, Sherry. Can you please have Dr. Boster answer the question? I appreciate it. Thanks.
So I would simply say that two things. Number one, this discussion doesn't replace you talking to your clinicians. And number two, in my clinic, 5 pounds doesn't make a lick of difference. And so I wouldn't be terribly concerned if we went 5 pounds up or 5 pounds down. That the different categories are more based on like 100, 150 pounds, 200, 250, stuff like that. And so at least for my patients, I wouldn't worry about a 5 pound change.
Thank you. Kim is asking you to talk a bit about MS and menopause. She's a 58-year-old postmenopausal female, wants to know about supplements, diet, and hormones.
Absolutely. So sometimes nature's too generous. And when a woman with MS enters into the perimenopausal state, which is typically around age 45-ish, or when they completely stop having a menstrual cycle, or typically around 55-ish, there can be some changes. And what's happening in the background is the ovaries, which make estrogen, are kind of winding down, and they're making less and less estrogen and less progesterone and less anti-Mullerian hormone. And in the setting of waning concentrations of estrogen, we can see a couple things that impact MS. Number one, we see that there's a slight increased risk of faster progression of disability, which is very disturbing. Number two, we can also see an uptick of symptoms. And the symptoms of menopause are yucky. And it's not just a hot flash. You can also see, insomnia, you can see fatigue, you can see changes in mood with increased irritability or depression or anxiety. You can see problems in the bedroom, not just with lubrication, but with achieving orgasm or decreased libido. You can see problems with bladder. You can see problems with bowel. And so that's really kind of yucky because a lot of MS symptoms mirror that. And most people impacted by MS are women. And so what do we do about that? Well, number one, there's been some really good research in this topic. And I always like to give a shout out to my friend, Dr. Riley Bouvet, who is an amazing MS neurologist out in California, who has done the lion's share of work looking into this. And there are things that we can do to counteract it. So number one, I would have a conversation with your OB-GYN. And I like a three-way convo between you, the OB-GYN, and your neurologist. And the request is to explore estrogen-only topical hormone replacement therapy. So it fell out of favor to give women hormone supplements in the past, and it's starting to come back in favor. It fell out of favor because there was concerns for cancer, which is very serious, and there's concern for blood clots, which is very serious. But oftentimes using estrogen-only hormone replacement therapy and using a topical like a patch or like a cream mitigates some of those risks. And oftentimes I have seen that we can ameliorate many of those MS symptoms. There is some research into this looking at other things that can be done. And it turns out that SSRI medicines like Prozac can help with these symptoms, which is a really big deal. In the question they asked about, supplements, and there's actually a supplement called Black Cohosh, which also can be very, very helpful. And so my recommendation is don't just say, oh, well, here's another bad thing that happened to me. On the contrary, get ye to your OB-GYN, have an engaged conversation, say, hey, look, this can affect my MS, it's impacting my quality of life, and I want you to help me navigate it.
Thank you. An anonymous attendee would like you to explain how neuroplasticity actually works and wonders if we can individually make an impact in creating new neural pathways, such as through exercise.
That's a great question. So I want to give a shout out to a friend of mine, Dr. Gretchen Howie. So if you don't know Dr. Gretchen Howie, you should because she's brilliant. She's got a wonderful YouTube presence. She has a program called Missing Link, capital M.
MSing,
Yeah, so
MSing link.
yeah, so capital M, capital SING, MSing Link. So look her up because she's phenomenal. She's wrote a beautiful book, and the reason I bring her up is she talks a lot about neuroplasticity, and she and I have had a lot of really engaging conversations about neuroplasticity. So neuroplasticity is really either A, strengthening the connection between a muscle and the brain, or building a new connection between a muscle and the brain. And that's real. That can actually happen. And the way that it happens is by repeated movements, motor movements that have been so you repeat a pathway and then you do it a million gazillion times. And so that's a very real phenomenon. If you have a weak leg, but you're able to move the leg, that means that there is still a pathway, although it may be damaged, there's still a pathway between here and there. And if that still exists, you can enhance and build that pathway through repetition. So that is a very real phenomenon. It's a very, very powerful phenomenon. And it really speaks to the fact that exercise is a disease modifying therapy. Exercise is a way of modulating MS pathology by reinforcing pathways and by neuroplasticity.
Thank you. And another anonymous attendee would like you to would like your thoughts on the effectiveness of Ampira in managing walking issues in primary progressive MS.
So Ampira, which is called 4-aminopyridine, or in Europe it's Fampira, is a symptomatic medicine. So it doesn't slow down MS. And so actually it has no bearing on what kind of MS you've been labeled with. PPMS, RIS, RRMS, it doesn't matter. What Ampira treats is a very, very bothersome symptom, which is kind of unique to MS. Some human beings with MS, when they get overheated, they short circuit and they can lose vision in their eye until they cool back down. Or they can start dragging their weak leg until they cool back down. Or they can get really, really dizzy and nauseated or numb until they cool back down. They have heat-related symptoms. And there's a lot of biology about why. In about 1/3, upwards of a half of people who take Ampira, it buttresses against that symptom, which is super awesome. So Ohio is one of these interesting states where I live, where you have a really cold winter and you have a really, really hot summer. So it's like, 90 out right now. It's just miserable. And a lot of my patients are struggling with heat sensitivity and motor fatigue. And so we test Ampira in a lot of our patients. Now, a couple words of caution. Ampira lowers the seizure threshold. So if you have had seizures, Ampira is a no-no drug. And so we have to be aware of that. My second word of caution is that in my clinical experience, it can take upwards of 2 months before we see a benefit from Ampira. So if you have heat sensitivity, independent of the kind of MS you have, ask your neurologist whether you would be appropriate to try a course of Ampira and try it out for about 2 months. In my experience, you either have what we call a Lazarus effect, like, oh my golly, this is amazing. I went out in the heat and I didn't get weak. Or you're kind of like, mm. And if you say, then it didn't work. But I would try it out. Absolutely. That's a great question.
Thank you. Maria just wants to thank you for convincing her to start on a DMT. She was diagnosed in 2014 and just started Kesimpta on Sunday.
Thank you.
So,
What an honor. I am super excited for you, and thank you for sharing that. That makes my day.
another anonymous attendee, can you please explain your thoughts on stem cell and CAR-T therapies? I'm 62. I was diagnosed in 2022, have RRMS, and I'm on Ocrevus, but my symptoms seem to be getting worse. So I do believe that I may actually have secondary progressive MS.
So let's talk about stem cell therapy and CAR-T therapy. So the common thread is that neither are FDA approved, right? So the common thread is that neither are available to be used by the FDA. The second common thread is neither are a medicine. Both of them are procedures. And a common thread is they both have significant risk. Now, beyond that, they're kind of almost polar opposites. Stem cell therapy, if I speak about it just broadly, you're going to harvest stem cells out of your body and put them on ice. So we're going to put them over here on ice. Then they give you lethal doses of chemotherapy to completely destroy your immune system. No more immune system, like John Travolta, like Boy in the Bubble. Remember that movie? So then, before you succumb to a cold, they give you back your stem cells and they allow it to reconstitute a new immune system. And the theory is that the new immune system would be less autoreactive. Now, stem cell transplants have been used for refractory cancers for a very long time, very successfully, with risk. And increasingly, they're being used in autoimmune conditions like multiple sclerosis. And I'm delighted to share that they're becoming safer and safer. There are places in the world where a stem cell transplant is covered. For example, in Great Britain, when you have really aggressive MS, then that's an option. Stem cell transplantation is not prime time, and it has a significant amount of risk. And so that's one type of therapy where you're really kind of like laying waste to the immune response and then giving you back one which you hope is more well behaved. CAR-T therapy is arguably the exact opposite. So CAR-T therapy, the word that sounds weird, CAR-T. So CAR stands for chimeric. So the word chimeric comes from the Greek mythology, the Shimra or the chimera, which was a mythical beast that was made up of lots of different animals. So like the head of a lion, wings of a eagle, like all these different parts, right? And the chimeric T cell therapy is really precision medicine, where, and this has been done in cancers successfully, and it's now being studied in MS. So, what they've done in cancers is someone has a cancer, which is killing them, and they take out one of their T cells and they genetically manipulate it and they give it a new target, and the new target is your cancer. And then they inject it back into you, and now you have a T cell specifically genetically engineered for your cancer, which goes and seeks out your cancer and kills it, which is really, really neat. And it's now being tested in MS, which is amazing. CAR-T therapy is precision medicine. It's the opposite of a stem cell transplant where you blow up the village. CAR-T therapy is not without risk, and about a third of patients in the trials for cancers had very serious cytokine storms where they had to be managed in the hospital. So it's not for the faint of heart, and it's super hella expensive, and it's very, very specific for that one human. So if you make a CAR-T therapy, you design a designer antibody for or T cell for that one person. It doesn't work in their twin. It doesn't work in someone else with MS. It's also not prime time. So both of these are very, very exciting frontiers in MS medicine, but neither are prime time just yet.
Thank you. I have it's not so much a question as a testimonial from Tom, who is 78. He says he had RRMS in the 70s, SPMS in the 80s with a slow progressive total recovery from all of his SPMS symptoms in the 90s. His leg braces are under the bed. He did a lot to recover. 4AP was major in his recovery. He says, do you know of other such long-term total recovery from SPMS disabilities? P.S. Xanaflex controlled spasticity with fewer side effects than baclofen.
So first of all, Tom, congratulations. That's freaking awesome. Like, yay. Second of all, no, that's super, super uncommon. Thirdly, I'll share that sometimes the thing that is destroying your quality of life is a treatable symptom. And I'll give you an example of severe spasticity. Spasticity is a monster which can cause a spasm or a cramp or a limb that's hard to bend. And so severe spasticity can put you in a wheelchair. If in this example you treat the severe spasticity, you might literally stand up out of a chair, which is amazing. So no, that's not common. And I am delighted to hear that you're doing so well. So congratulations. And that's really, really cool.
Thank you. An anonymous attendee says, my last infusion was right after my brain and spine MRIs. How quickly is the contrast out of my system? Are there any risks associated with having contrast in my system so close to my infusion?
Very timely, hotly debated question. So there are no concerns largely with the infusion in the contrast. In fact, at the Boster Center for MS, we do MRIs the same day that we do our infusion therapy. However, there's a couple things that we have to be very aware of. So the first thing is that the contrast lights up all the blood vessels so you can see them, and it's supposed to stay in the blood vessels unless there's a new breach of the blood-brain barrier because of new active inflammation. And then temporarily, the contrast will leak out and it will cause an enhancing lesion or a gadolinium enhanced lesion. And this can be very, very important, particularly when diagnosing MS. It's less important after we've made the diagnosis. And there are some neurologists that are starting to shy away from contrast. There are two different kinds of contrast molecules. There's linear contrast molecules, like a line, and linear is bad. And there's macrocyclic, like a circle. Macrocyclic molecules are safer. And the reason linear is bad is because those stick around, they get sequestered in your kidneys and maybe your brain, and that's bad for you. So you want to make sure that the MRI facility is using macrocyclic molecules. Secondly, if you have kidney damage, we have to be aware of that when we do the MRI because it might not be safe to give you contrast. I prefer to use contrast in my scans, all things being equal. So if I have a choice and my patient has normal kidney function and they're willing, I want contrast because it teaches me a bit more about how they're doing. If the patient is uncomfortable, then we just don't do it because we don't do things that patients don't want to do because you're in charge of you. I will share a recent example which made me feel kind of reassured that using contrast still has value. A delightful patient of mine who came to visit me, and he's been my patient for a very, very long time, and he's been stable for a very long time. And he was doing clinically like okay-ish, but he had a new leg thing. And he wasn't sure whether it was a significant new leg thing or not, but it was bothering him. And we got an MRI with contrast, and the flare, we talked about that earlier in this lecture, was the same, but there was a new enhancing lesion. And if we hadn't done contrast, we wouldn't have learned that information. And so that actually changed our management. We reinterpret the leg thing along with the contrast to think we're having a new disease activity. And honestly, I might have missed that if I hadn't given the contrast. It's a great question.
Thank you. This individual is 63. They were diagnosed at 59, so 4 years ago. They are on have been on Rituxan for 2 years and then switched to Tysabri, but they're wondering if it makes sense to go to Mavenclad and if Mavenclad would manage or control their disease at this age.
I can't remotely answer that question because I don't have nearly enough information. So I appreciate you asking the question, but I would literally need to do like a 2-hour consult to extract all the relevant information before I could really weigh in. So I'm going to defray from asking or answering that.
Thank you. Another anonymous attendee, how would you, in all caps, how would you recommend explaining MS to a loved one?
So at the risk of sounding self-aggrandizing, I have a YouTube channel that I made to help empower and educate and to energize families impacted by MS. And I have several videos that I've made on how I explain MS to family members. So you can check out my YouTube channel where I talk about that quite a bit. But if we answer the question, what I would share is MS is an autoimmune condition where your immune system is misbehaving and it's attacking part of you. So like friendly fire, like you're not supposed to shoot your buddy on guard duty, right? And so there's lots of autoimmune conditions like lupus is an autoimmune condition that affects the blood vessels. Diabetes is an autoimmune condition that affects the pancreas. Rheumatoid arthritis is an autoimmune condition that affects the joints. MS is an autoimmune condition that affects the holiest of holies, the supercomputer that runs the body, the brain, and the superhighway, the spinal cord. And depending on where that attack occurs determines what kind of problems the person has. And so that's where I start the discussion about MS, trying to help a family understand. Another thing that I find really helpful, particularly when talking to children, is there's a book out which I love. I don't know that it's published anymore, but you can find it through the interwebs. It's called MediKids. So I don't have a financial relationship with this company. I just love them. MediKids, which is Medikidz. And this is a graphic novel where they explain chronic conditions to children. And they have a book on MS, and it's phenomenal. And so do a search, and if you find it, buy it. And that is a fantastic tool to sit down and read with your children to help them understand the condition.
Thank you. We here at the Multiple Sclerosis Foundation also have a couple of books that are illustrated to, one of them is Monkey Snot, MS, and it talks about a child's perception of what their parent is experiencing. There's also another one that talks about how to explain MS to children. So go to msfocus.org, go to our publications, and you'll see those books, and we will mail them to you for free.
That's amazing.
So just let us know. And Dr. Boster, if you need some of those books to have on hand in your clinic, just let us know.
Please.
This individual, again, another anonymous attendee, said they were recently diagnosed with MS and a month and a half later, a rare type of B-cell leukemia. The hematologist feels that the cancer may have triggered the MS. They're unsure of how this works. Is it possible that the chemo, which is cladribine and obinutuzumab, could reset the immune system enough to make the MS dormant? Anything else to share about the MS cancer relationship?
So sometimes nature's too generous. And that's an unfortunate and scientifically kind of fascinating situation. And I wish you the very, very best. I'm also very encouraged because one of your chemo medicines is also an MS medicine.
The
So
cladribine.
cladribine, by a different name, is Mavenclad. And Mavenclad, I view as king of the pills. It's the most effective oral agent that I've used in my practice to treat MS. And so I'm really kind of delighted that your oncologic therapy will also treat your MS. Is it possible that treating the cancer will make the MS dormant? Yes, it's possible, particularly when chemo crosses the blood-brain barrier, which many of them do.
Thank you. Sabrina lives in Tennessee, but she would like to come and see you. Do you see patients out of state? She's seeing a neurologist now, but not an MS specialist.
Gosh, Sabrina, that's really, really nice of you. There's a bunch of MS specialists between you and me, but I'm honored that you'd want to come see me. I actually have a Tennessee license on purpose. I require patients to come to the Boster Center twice a year in person because I'm old school and I want to actually physically examine you. But I have a lot of patients that come from Tennessee, and in between those biannual visits, we do telemedicine. So make a road trip and come on up to Ohio and visit.
Thank you. An anonymous attendee is a 59-year-old female with relapsing remitting MS. Her neurologist gave her a nerve block injections for the second time in the head for severe burning pain and facial spasms with other symptoms. The annual MRI showed no new spots. If no new spots, why do the symptoms worsen or I get flares? Please advise.
That is a great question. So thank you, Anonymous, for asking that question. How is it that I can have ongoing problems and yet my MRI is stable? It's because the old damage is still there, right? So let me use a couple analogies. If some Yahoo crashed their car into your living room, broke down the living room wall, there's a car in your living room, and you clear out the car and you clear out all the debris, every single time it rains, you're going to get wet if you're in your living room because there's a giant hole there and it didn't get repaired, right? Or another example would be, let's take an electrical wire. Okay, let's pretend this is an electrical, like an extension cord, and your husband ran over it with a lawnmower, but he didn't tell you, and he just duct taped it up, right? That's like something I would do, right? This wire now works 90% of the time. And under normal use, if you plug one thing into it, it's fine. If you plug five things into it, it's going to short circuit. Every single time you put too much on this wire, it's going to short circuit. That's your spinal cord of your brain. So my point here is, if you have old damage, as you age, that old areas of damage can wear out, and we can see progression of disability, and we can see ongoing chronic symptoms in the absence of new lesions or new attacks. And the reason that's such a good question is it's so important to understand that concept. Sometimes doctors, maybe without intention, misinform or miseducate patients to think it's all about new attack versus no attack, new spot versus no new spot. And that's part of the disease. But there's another actually larger part of the disease where areas of damage can wear out over time. And we can see chronic symptoms or progression of disability independent from attacks. So thank you for asking that question, giving me a chance to talk about that.
Thank you. An anonymous attendee, female 57, is postmenopausal by 4 years and progressing rapidly. They use a wheelchair and rollator. They were diagnosed only 18 months ago after about 25 years of symptoms that were written off to fibromyalgia. They just want everyone to know how important it is to push to get a diagnosis and to be your own healthcare advocate. They're currently on Ocrevus.
I agree.
Selena says, I'm on Kesimpta. I'm 54 with relapsing MS. What are your thoughts on vidofludimus calcimuit? This calcimit
Yeah.
seems to be all over the MS news, and they're calling it a game changer.
So in full disclosure, I was involved in the phase 2 trial for this drug. I chose not to do the phase 3 trial because it's a placebo-controlled trial, and ethically, I didn't think that was acceptable. It's a long-acting Aubagio. So I'm not so sure that it's a game changer, but I'm always delighted when there's new options available. Aubagio is a well-known MS medicine, which is well described, and this is kind of tweaking it. So it's almost like an Aubagio Me Too drug. And I was very delighted that we were able to participate in the phase 2 trial. But that's what I'll say about it.
Thank you. Caroline says, what are your concerns when switching from Zeposia to a stronger medication like Ocrevus?
So Zeposia is an S1P1 receptor modulator. That's a mouthful. It's a pill, and it's in the class of medicines like Mayzent and Gilenya. And when you take these medicines, they lock away or sequester your lymphocytes in your lymph nodes. And then when you stop them, they come back out. When you stop one of those medicines, we have to be aware that sometimes the cells can come out too fast and kind of bum rush the bloodstream, and they can go to the brain. And very rarely you can see a phenomenon called IRIS, IRIS, which is immune reconstitution inflammatory syndrome, which will make you really sick. So when you switch off of one of those drugs to a different drug, we need to be smart about how we do it. And the key is not to have a long period of time between drug A and drug B. What you don't want to do is stop that medicine, wait 3 months, and then start the next one, because that's a risk for rebound. So instead, I like to start the next medicine very, very tightly, like within 2 weeks or 4 weeks. And sometimes I will give patients steroids to quell the differential return of the cells, but that's a little bit of like MS voodoo. And so that's what I'm thinking about when I'm making that transition.
Thank you. Machika is asking a question about a comparison between two of the BTK inhibitor drugs. Which one is better for non-relapsing secondary progressive MS or smoldering MS? Now, these drugs have not yet been approved by the FDA.
Yep.
So we don't know which is better. We're more likely to see the tolobrutinib approved by the end of this year, potentially. The Fraxylamab,
Fraxilizumab, yep.
yep, that drug is a little bit farther back in the testing um, uh, pathway. So it'll be at least probably a year before we see that, you think?
Even more. So Fraxilumab is not a BTK inhibitor. Fraxilumab is an anti-CD40 ligand. And I didn't make up any of these words. It's kind of like putting a condom on a T cell so it can't connect with a B cell. Tolobrutinib is a BTK inhibitor, which turns off some of the internal machinery of the B cell and the microglia. And tolobrutinib was tested in relapsing MS and didn't work. And it was tested in secondary progressive MS in the Hercules trial, and it worked. It decreased disability progression by 29% compared to placebo. It's tolobrutinib is tested in the Perseus trial, which we're involved in, which is looking at PPMS, and we don't have data yet. Now, Fraxilumab, I call it Frexa because I can't say that word. Fraxilumab is an infusion in the vein once a month. And at the Boster Center, we're currently testing it in relapsing MS and secondary progressive MS. But as Sherry said, we're right in the middle of the trials. We have no data yet. So I am delighted that that person is so in touch with kind of what's going on in the MS research space. That's fantastic, but it's a little too early to comment.
Thank you. Karen asks if there's a trend where older people are contracting MS more frequently than previously, and if so, is there a reason?
I don't think that there's a trend in people developing MS at an older age. I do think that there's an uptick of MS, particularly in women internationally, for reasons we don't know. And I'm delighted that I think there's more general societal awareness about MS, bringing it to the forefront of clinicians' minds so that we can think about testing for it sooner.
Okay. Brenda has a question about the remyelinating therapies, specifically related to metformin. She's taking metformin for her type 2 diabetes and wants to know what dosage is being tested.
So metformin is a really cool drug. It's invented and FDA approved for use in certain types of diabetes. And what it does in the body is weird. It creates almost like a fasting state in the body. And there's been some early research suggesting that it actually may help in remyelination. I will opt not to answer the question with a dosage because I don't want people to go out and manipulate their metformin doses. But what I would say is you're probably getting a twofer because the medicine that you're using for your diabetes may also play double duty in helping you with some early remyelination. The jury is out. We still don't have prime time for what metformin can do. And so we always have to take that information with a grain of salt.
That also relates to the GLP-1 drugs. Ozempic is also showing up in some of these studies. Similarly, we don't have enough information yet for people that might be kind of dovetailing onto that question.
Correct.
Um, let's see. Oh, I scrolled down just a tad too far here. An anonymous attendee says, at what point do you decide it's time to go into some type of assisted living facility? What is the deciding criteria?
So for me, that discussion has everything to do with safety and with getting your activities of daily living managed. So, for example, some people aren't able to get food and prepare meals for themselves any longer. Some people might not be able to get up and get into the bathroom by themselves. And in those scenarios, we want assistance so that they can thrive and live their best life with dignity and they can meet their nutritional needs and all those kind of things. And there's a lot of different ways to do that. Sometimes we bring a helper in the home. Sometimes we move into an environment where those helpers are found. And so I think that it's very, very individualized. I don't think there's a set time and place, and it's not for everyone. But if you're not able to provide your activities of daily living by yourself, showering, bathing, toileting, feeding yourself, then I want you to reach out for help because there's help out there so that you can achieve those goals.
Thank you. We've got about 5 minutes left, and so I'm just going to be real quickly selective about a couple of questions. Um, One individual has a 52-year-old female with secondary progressive MS. She's JC positive, stable MRI, taking dalfampridine and Ocrevus. Disease progression is happening much more quickly than she thought and has been told that she's a no options patient. What do you do for people in that situation?
I think that's BS. I don't think that makes any sense whatsoever. So I would find a different neurologist.
Um, Caroline's asking, what are your thoughts on the benefits of fasting?
I think intermittent fasting is genius. I have several YouTube videos on the benefits of intermittent fasting. And I think it's a really, really cool tool.
Joy asks, I was diagnosed today. This is Joy from Facebook. How do I explain this to my children?
So, Joy, you've got a journey ahead of you. I want you to lean on resources from the MS Foundation. So, the group that's sponsoring this Q&A is remarkable at helping patients with this process. And in fact, if you ask Sherry, she'll mail some resources to your home.
And Joy, if you email me, Sherry at msfocus.org, we can have a conversation with some of the specifics that concern you, and we'll tailor a conversation to what you need. For anybody listening here, if you have questions that don't completely make sense to you or you need more information on, don't hesitate to email me, Sherry at msfocus.org. We also have Sherry from Facebook asking, how do you feel about hormone replacement therapy in 60-year-old woman with MS?
I love it.
Thank you. Anonymous attendee asks, can you please talk about heat intolerance in MS? It's a condition common to me. Is it common in MS to almost pass out and feel nauseous when warm, specifically for me if I'm out for a walk? And why does this happen?
So yes, it's actually pretty darn common in the setting of MS that when a patient heats up their core body temperature, whether because they're in a hot climate and it's warm outside, or because they're exercising or having intercourse, or because they're sitting in a hot tub or because they have a fever, because they have a urinary tract infection, when they raise their core body temperature, they can have short circuiting. Heat sensitivity and motor fatigue is very, very common. Very quickly, two things that we can do: we can use cooling tools like a cooling vest or a cooling hat. We can also think about medicines like Ampira that we spoke about earlier during this Q&A. And so lots to learn about that, but don't accept that laying down.
An anonymous attendee wants to know how you know when is the right time to start treatment, and how do you go about picking a drug to start with?
The earlier you start a therapy, the better. So I would start a therapy as soon as I was diagnosed. And in some cases, I start a therapy even before I'm diagnosed the patient. So the earlier, the better. The earliest application of the most effective therapy that you're comfortable with is the recipe for success. Do
Thank
not
you.
wait.
And Karen puts into the question and answer, Dr. Boster and Sherry, you are my heroes. I've learned so much from the two of you.
Thank you. That's really sweet of you to say.
Thank you. It looks like we are at the end of our time together. Dr. Boster, I thank you so much for taking this time each month. For those of you that want more, and you didn't know about it, Dr. Boster is literally all over the YouTube arena. He has his own YouTube channel, and there are several archived videos in the Multiple Sclerosis Foundation YouTube channel that he has done too. So please avail yourself of his videos. Subscribe to his YouTube channel. And our next event is going to be this coming Monday, the 30th of June. Gosh, can you believe it's the end of June already?
Wow.
With our 100-degree temperatures this week. Dr. William Conti is a member of the LGBTQ community, and he's going to be doing a talk on Monday at 6 p.m. Eastern Time on health disparities in MS in the LGBTQIA plus community. So join us for that. And then also that following week, you get me back again with Ask the MS Nurse on Tuesday, July 1st, and Dr. Ben with his Ask the MS Expert on Tuesday, the 8th of July. So there's lots of room for you to get answers to your questions. And again, if something came up triggered as a result of this that you need an answer to, don't hesitate to email me, Sherry at msfocus.org, and I'll get the answers if I don't know them. Thank you. And good night, folks. Stay on the line if you're on Zoom for a quick survey to let us know what you need to hear from us
Thank you.
in future events. And thank you.